Thank you for the invitation. I'll speak about something which is actually close to signal processing, etc. So it's close to electrical engineering. A quick introduction. It is well known that the cases trajectory that we see is not representative of the disease burden or the infection prevalence. That's because usually these are based on testing. People that are more sick go to the hospital and then contact tracing, etc. tends to bias the cases that we see. And so what we need is an unbiased estimation of infection prevalence to devise effective public health responses and public health management strategies. These are usually done using serological surveys, and these detect antibodies that survive for some length of time, immunoglobulin G, for example. Now, I want to highlight one particular serosurvey that we did for COVID-19 in Karnataka, and that is around 2020 September-October timeframe. So this was a time when there were quite a few cases as well. So you can see the box there that indicates the time when Karnataka did its COVID-19 serosurvey. So one thing that strikes us at that time is, of course, there is possibly people that have gotten the disease, but there are also many that are actively having this disease. And if you're looking at serosurveillance alone, that wouldn't suffice to estimate the disease burden, because these antibodies take some amount of time before they become detectable. Now, we would have missed a significant fraction of those who would have had active infection at the time of the survey. And so we must estimate, at least in that particular circumstance, both active infection, people that are suffering from the disease or have the virus, and also people that suffered the infection in the past. So if you think of total burden as something that takes active infection as well as past infection, that's what we would like to estimate. And estimating that, because there is also active infection, you need multiple kinds of tests to capture them. Now, here are the various tests which we are familiar with now. RT-PCR test, rapid antigen test, and antibody test. The RT-PCR and the antigen test for active infection, whereas the antibody test for past infection. And to estimate the total burden, what you would do is recruit participants, and then administer one or more of these tests. So there are these questions that arise: what tests to administer? Would it be only RT-PCR, only the antigen test, only the IgG test, or maybe a combination of those, RT-PCR and IgG, for example? Also, if you want good estimations, how many participants should you recruit? That's the kind of question that optimal design actually answers. Now, I want to highlight the kind of design that the Karnataka serosurvey had come up with. This was actually something that took quite a bit of time and discussion before they arrived at it. And it involved population strata of this sort, people that had low exposure, people that had moderate exposure. And then somebody suggested that perhaps while we are doing this, might as well get what fraction of the vulnerable have suffered from the infection. And then there were the antigen tests and the RT-PCR tests. So why not maybe try both of them and see how effective they are. But then the antigen tests cost money. So perhaps on the low exposure people, they are unlikely to have possibly active infection. So let's save a little bit on that and so on. So some sort of an ad hoc design, taking into account cost considerations and also the kind of population that we wanted to see to what extent they were affected by this, led to this sort of what I call a design by committee. And this is a sort of nightmare for statisticians to work with. And this is what we had to deal with when we were invited to do the statistical analysis for the serosurvey. Here I have listed what ought to have been the considerations. For example, we have to take into account the test costs. They are important aspects. The antigen test, for example, cost about 450 rupees when we were doing this. The RT-PCR test was around 1,600. They're much cheaper now, and the IgG tests were about 300 rupees. There were different sensitivities. The antigen test had a sensitivity of roughly around 0.5, and specificity was good, but sensitivity was quite poor. The RT-PCR test had better sensitivity and specificities, Those were indicated there. This was for the particular kit and the method that was being used, and the IgG test had those sensitivities. Now, I would like to just answer this question: what kind of tests to administer, how many participants to recruit, etc. So to pin this problem, to formulate it, first I would like to put down some definitions. Suppose there are 3 tests: the antigen test, RT-PCR test, and the IgG test. A test suite is a subset of tests that are conducted on one particular participant, and we have the collection of all possible test suites. Here's how, if you conducted different tests on different individuals, or different test suites on different individuals, the data would look something like this, where there would be maybe a subset of tests conducted on some individuals, and the corresponding outcomes, positive or negative if the test was conducted, and an NA if the test was not conducted. So you can see that the kind of data that you would get is somewhat difficult to manage, to extract information from. That's something to keep in mind. The other thing that I would like to define is something called a survey design. It's just for how many participants would you want to recruit for a particular suite of tests that you want to conduct. So if you have a pair of tests that you will conduct, how many participants for that? Maybe there might be 5 that were administered only the IgG test, 10 that were administered the antigen test and the IgG test, and so on. And this is the thing that we would like to identify. This is what is called the design. And there is an associated cost for the design. So if you recruit WT participants who will be administered a test suite T, then there is a certain cost associated with them, which I call CT. And so this summation here is the total cost of this particular design. If you have this design, there is of course the cost that you have to incur, but how good is this particular design? So we need to address the performance question. To address the performance question, let's actually go back to addressing the statistical question of, if I get data like this, which is given here, I administered a suite of tests on these individuals, or a collection of suite of tests on these individuals, and those are the outcomes. How would you estimate what the disease burden is? For example, one could look at just the antigen test outcome and then estimate past infection, or just the RT-PCR test and estimate active infection. But then if you look at the combination, if somebody has a positive IgG outcome, then that actually enhances possibly a negative evidence for the RT-PCR test. And so you can combine these tests in some way. Also, there are significant variations in the test suites that are administered across participants. The test outcomes are noisy, and therefore those enhancements can help. And if you look at just counts of IgG, it will give you only partial information. You want the entire disease burden. So counts by themselves do not use all the information available. So to do the analysis, what we had come up with is a simple model and then an estimation procedure. So our model had a 4-state model where a person could have active infection but no antibodies. Person could have antibodies indicative of past infection but no active infection. Or the person could actually have active infection and also develop some quantity of the IgG antibodies which could be detectable. Or the person has not yet been exposed to the virus, or perhaps had another way of fighting a past disease. And so if you could find out the fraction of the population in each of these states, in our model that exhausted all the possible states, then if you could estimate that, then the disease burden is those in the first 3 states. What fraction of the population is in the first 3 states? So what we then came up with is a measurement model based on these states. So if somebody was in one of these states, let's say, then there are nominal outcomes for each of those tests, but the tests are noisy, and therefore they are indicated by these what are called transition probabilities, or in statistical or communication engineering parlance, channels. So if somebody is in, let's say, a particular state, what is the chance that the outcome of a particular test is negative or positive? So using these sensitivities and specificities, one can compute all of those and come up with then an estimation procedure. The problem is which state an individual is in, knowing these outcomes, it's a little uncertain. So you have to essentially try to work backwards. And The state is hidden, unseen, and our goal is to estimate what is the fraction of the population in each of the states. And if you then sum up 3 of the states, that gives us the disease burden. So the transition probabilities, etc., a little bit of statistics in here suggests that we can write down, if we know the states, if we know the fraction of population in each of those, what are the likelihoods of seeing a certain outcome given the test suites. And then once you have these sort of formulae based on the observation, you can go back and estimate what the underlying parameters are that led to these observations. And that's the maximum likelihood estimation. And this answers an estimation problem. What is the best P that explains the observations that we see, and therefore the disease burden. Now, a little bit of classical statistics here. Now, if you sample enough individuals, these estimates are consistent, and therefore one will be able to get, at least in a model situation, these estimates will go to the true estimates. And also they are asymptotically normal, in the sense that your estimated value will be close to the true value, but there would be some noise around it, and the estimation error is something that you can characterize, and you can write out its variance, etc. And this variance is essentially what we would like to optimize, and that variance involves some quantities like the Fisher information matrix associated with the particular test design, with the particular survey design. And so when one is doing the estimation, one estimates the maximum likelihood, gives the maximum likelihood estimate, but also can provide what the confidence interval is. This is actually, when you look at this variance, it's actually for the entire vector. It's a covariance matrix. But here we are interested in a certain P1 plus P2 plus P3, that is the first 3 states. So it's a linear combination. So you can write out the variance estimate for this. And what this gives is all the confidence intervals that one needs along with the estimates. A little bit about the Fisher information matrix from which we get this particular quality of our estimate. It depends on the survey matrix, on the survey design, and the more people we recruit, the better this particular matrix, the greater the ability to be able to identify what the underlying state is. Now, this estimation procedure is what we did for Karnataka in actually 2 serosurveys, one in September of 2020 and another in January, February of 2021. So we did this survey in 290 sentinel sites. All the 30 districts of Karnataka were covered, and Bangalore, because of its large size, was split into several subunits. And the way it was done was the state's AIDS prevention and tuberculosis surveillance team was leveraged to conduct the tests. You can see the kind of variability that we saw. So these are the confidence intervals. There was significant variation in the fraction of the population that had seen this infection, with Bangalore and a few districts close to Maharashtra showing quite a bit of high prevalence, whereas there were some others which were low. Now, at the end of the first serosurvey, we actually provided this map to the Karnataka State's Department of Health and Family Welfare Services, where it identified how each of those districts were performing in terms of their infection fatality rate as well as the cases to infections ratio. We didn't have any basis for spatial variation of the infection fatality rate, and so if the infection fatality rate was perhaps low and the cases to infections ratio was high, maybe there was circulation, but cases were being missed in those areas. And so some action had to be taken in some of those districts. And if the infection fatality rate is high, but the cases to infections ratio is low, perhaps these districts are districts where surveillance activity is going reasonably well. And maybe the practices there could be emulated in the other place. You would see Dharwad here with a very high value of infection fatality rate. It is something that's because that's one of the hospital there is one of the places which serves several rural communities, and therefore the infection fatality rate somehow is higher there. Now, these were the kinds of reports that we gave to each of the districts. This one is for Chitradurga, which I had visited, and the district surveillance officer would have had the observations as well as the recommendations on what sort of actions to take and so on. Now, was this which we used in the 2020 September serosurvey the best design? And that's where optimal design comes in. So if you have a design, you can come up with an estimate and a confidence interval and so on. But if you were to go take a step back and come up with the best design, taking into account cost considerations, what would you do? So for this, we had to come up with a performance metric, and the most natural performance metric is basically the confidence interval. How small is that confidence interval? The smaller the confidence interval, the better. So here is a design problem that one can formulate. I'm given a budget C of a certain amount of rupees, and I know what each of those tests cost. What's the best survey design? That is, how many participants should I recruit and administer an appropriate suite of tests in order to minimize the total minimize the variance of the total disease burden estimate. Now, since I indicated this Fisher information matrix, etc., so this is the actual variance of the estimate, and one would like to minimize this across possible survey designs, subject to a certain cost constraint, and also the fact that you need to recruit a positive number of people. Now, the number of people that you would recruit is integral, but one can relax it and look at this optimization problem and solve for this and then approximate it to get the outcome. So here is a concrete example to motivate this particular problem. Suppose I had a test suite of, let's say, the antigen test, but I don't administer the RT-PCR test, and then I administer the IgG test. For the costs that I had indicated, that would have been about 750 rupees. 450 rupees for the antigen test and 300 for the IgG test. Now, if you look at another option, which is the RT-PCR test at that time, which was about 1,200 rupees, and then the IgG test, that's about 1,500. So, would you rather conduct one test, which is RT-PCR and the IgG, and get more certain, perhaps more reliable answers, but only one sample, versus recruiting more individuals, 2 people, on which you administer a poorer test, the antigen test, but you're able to get perhaps a slight, you can leverage perhaps more number of samples. For the cost of one of this variety, I could administer 2 of the other variety, which is better, or perhaps a combination is important. So, before I give you the answer for this particular formulation, which is a reasonably simplified formulation, I want to go back to the instructive case of a single test. So here, I'm given a certain budget and there's only one IgG test and it costs a certain amount. Let's say that n of these tests are administered, then the best estimate is what fraction are positive, and that has a certain variance. When you come back to the estimate, that estimate has a variance which is given by p times 1 minus p divided by the number of people that underwent the test. So to minimize variance, you should have as many tests as possible. That's what this is saying. So here there is no question of design. You just have to use all the budget that you have. And if you have a certain budget C and you have a certain cost, the number that you can recruit is at most given by that quantity C divided by the unit cost. So the minimum variance then has this behavior where there is some dependence on the current state of the infection, that is the p times 1 minus p, the cost, and then the total cost comes in the denominator. So this picture indicates this. If you have a certain budget, this is the kind of accuracy that you can get. The larger the budget, the smaller the variance, and the variance goes down in this particular way. Now, when you have a more complicated set of tests and an optimal design question, the answer is actually very similar. So once again, as you have a larger and larger budget, you can improve your variance. But the design that you can do is essentially something that shifts this curve up and down, and the optimal design is something that brings this as low as possible. And here is something called C optimal design. It involves optimization of a particular function, so these variables can be interpreted as what fraction of the budget should go to a certain test suite, and one plugs this in and then tries to find this numerically usually. Now, one interpretation here is that you might have an extremely good sensitivity and specificity for a test, and that's actually measured by this Fisher information matrix associated with the uncertainties that come from the sensitivities and the specificities. But then if it is too expensive, you have to discount it. So that's the kind of intuition that one gets. So if you solve this, that will tell us what fraction you must invest in each of those test suites and the number of people that you recruit. So this is the amount of funds that will go to that test suite, and because the test suite cost is CT, that's the number that you will recruit. So here are some numerical examples just to give a feel for the answer. So if the antigen test costs 450 rupees, RT-PCR test costs 1200, and the IgG costs 300, and you were to do an optimal design, then the fraction that are undergoing there would be people that undergo only the IgG test, and there would be those that undergo the antigen test and the IgG test, but no RT-PCR test because it's a little too expensive. And the number that are recruited for IgG alone is 1/16 of the number that are recruited for the antigen test and the IgG test. On the other hand, if this comes marginally down to 1000 rupees, then we don't do the antigen test at all and do only the RT-PCR test and the IgG test for 3/7 of the population, sort of answering one of the questions that Gautam had posed. Now, did we take this design back to Karnataka? Yes, we did, and for the second serosurvey, we said do away with the antigen test for the kind of accuracies that you need, and the estimated guessed prevalence, just the RT-PCR test and the IgG test would suffice, and that's what we implemented in the second one. There are a couple of extensions that one can do. For example, you need a guess to come up with your guess of the disease prevalence to come up with the optimal design. But then in reality, you're actually trying to figure out what is the prevalence there. So in such circumstances, one comes up with a worst case design, and there is something that we can say about that. Also, we noticed after the first serosurvey that the antigen tests were a little more sensitive on the symptomatics versus the asymptomatics. So they had 68% sensitivity compared to only 47% on the asymptomatics. And so when we see a participant, we know whether the person is symptomatic or not. So we can make a test suite choice based on the symptoms that this individual presents. So one can solve that problem also. I will not go into the details of that. Quick summary. So the key way in which we solve the statistical question is to come up with a parametric model that enables the 4-state model, and taking into account the sensitivities and the specificities that enabled us to estimate the disease burden. And then that told us that if you were to do a better design to minimize the variance of the estimate for a given cost, then there is a certain optimization problem that you should solve. It's sort of like what is called the C-optimal design in classical statistics. The solution is a simple one, and the test proportions are such that they don't change with the budget. So that's another interesting property, and these are kind of related to some classical work that Chernoff had done in 1953. So it's really reusing some of the technology that Chernoff had developed. I would like to just thank several people that were involved in this design, as well as in taking it to the Karnataka state to be able to implement this design on the ground. Thank you.
What about the decay of antibodies?
Yes, so we did not take into account the antibody decay. This was a big problem in the second serosurvey particularly. So in this analysis, I have not done that, but in estimating the disease burden for the second serosurvey, we actually had another test where we recalled people that were positive on the first occasion and estimated what fraction of them were still testing positive. And it was it depended on the test. The sensitivity was somewhat low on the old kits, but there were some newer kits which were good. On the old kits, I can even give the numbers. It was about 42, 43% or thereabouts. But there were some more sensitive kits which were able to identify that 80% of them still had the IgG. So, but because we had used the old kits, we had to use those sensitivity numbers for the estimate. It was appropriately noisy. Yeah, it's OR. It's also there's quite a bit of this in signal processing where you do channel estimation and things like that. So
signal processing people are moving into OR.
Yeah.
This Dharwad case where you had high IFR, older population. I mean, IFR is IFR, right? It's
it's not population. So when we look at that number of cases, etc. So we are going to sentinel sites, which are hospital sites. But there are people coming from other districts to Dharwad because maybe it is proximal and we are actually capturing cases there. So the IFR there is reflective of people that possibly got the disease in one of the neighboring districts and then came over here, or neighboring places and came over here.
Oh, I see.
Yeah.
So the denominator is small, but the numerator is large because you're taking people from.
Because it contains people that have come to the hospital for healthcare.
Rajesh, this might be a naive question, but if you want to continue to estimate this over time, how long do these antibodies last? And because, and especially as variants come in, my understanding is that the spectrum is a little bit more complicated. And I was thinking how would it apply as COVID is moving through the population now after 2 years.
So I think there is antibody waning, and this waning has been characterized as well. There is some model for that. As I mentioned, there was significant amount of waning that we saw as measured by the kit. It's also a function of the kit that was used. So your question, if I understand correctly, is how would you adapt these strategies that are here to take into account those wanings. Now, if you, I'll just go back to that particular model that I had, which was a 4-state model. And in that 4-state model, once somebody had the disease, a past infection, our model was something which was flat from that time onwards forever. And therefore, you would capture the past infection in that model. So this is an idealistic model. Now, to bring in, if you have a model for antibody decay, you could look at what is the positivity probability upon being tested, bring that into the picture. So that is possible to do. It makes the model a little more complex, but it can be done. But it also now has to take into account perhaps when each agent got the infection and what the decay is. If there is a population characterization of that, so if you can write some ODE of that, then that would help. But if not, then perhaps one might need an agent-based model way of looking at that. So it's something that has been on our minds, but we haven't come up with a good simplistic model for that yet.
You want a simple model. Have you considered looking at using probabilistic
So in this case, so probabilistic cellular automata would be maybe agents that are going through, maybe interacting with each other. It would get a little closer. So I think some such thing is perhaps what these agent-based models would be doing through interactions, etc. And one would need some such model to be able to answer the question that Madhav asked. Which is with waning, now you have to come up with an optimal design. In fact, this was a question that we were struggling with. It takes enormous amount of planning to be able to run this. Of course, it's much simpler than what we heard in the previous talk, but nevertheless, some amount of time, and the antibody waning is a significant issue. And we just went to the second round saying, let's see what we get. And then we had to come up with a corrective mechanism where we had to recall some of the participants from the first survey to be able to understand to what extent they were still positive on that same test. But if we had a better model for that, that would, through these cellular automated model, agent-based model, I think we might have done a little better, but I'm still thinking about them. It's a good question to ponder about and address.
Anybody? Then let's
Yeah, thank you.
Oh, was it